to go. I believe we are officially live. Thank you so much for joining us on this Friday, March 10th, as we discuss the diagnostic journey of cerebral palsy with Dr. Edward Hurvitz here, who is a physiatrist and also chairman of the Department of Physical Medicine and Rehabilitation at the University of Michigan. So go blue, as I said previously, go blue. We're so grateful to have you and to help our community today. I'd love to just get started by having you introduce yourself and kind of your journey towards becoming who you are and where you are, and what led you towards this field.
Sure. Thank you. Thank you. Well, thanks, everybody. And I'm just really happy to be able to talk about this today. So I'm from Southeastern Michigan my whole life, Detroit area. And when I, always wanted to be a doctor since I was 12 years old. And then when I got into medical school, I got exposed to the field of physical medicine and rehabilitation. It's a relatively new field. It started in 1947, which makes it one of the newer medical specialties. But I was exposed to a clinic that was led by a famous orthopedic surgeon who's no longer with us. His name was Dr. Castle from Detroit. And Dr. Castle had a clinic where he had children, where he had physical, occupational, speech therapy. He had a teacher. He had other specialists there. And I thought that was a fascinating way to practice medicine. And I found children with disabilities to be something that really touched my heart, but also touched my brain in terms of being very interesting, because I got very interested in the idea of what it's like to grow up with a disability, how that affected a person's life, how that changed things for the person. So I did a residency at the hospital that used to be called Sinai Hospital of Detroit. It's no longer there anymore. And then I did a fellowship at the University of Michigan in pediatric rehabilitation. I've been at the University of Michigan for 35 years, and after about 18 years there, I became the department chair, and I needed to decrease my patient load. So I kept more patients I knew better, and I had a clinic full of adolescents and adults because I'd been there so long. So I got interested in adults with cerebral palsy. So now a lot of my work is around what happens when you grow up into adulthood with cerebral palsy, and I have quite a following of adults with cerebral palsy. We've done a lot of research in that area about their medical outcomes and healthcare. And that's basically my story.
That's amazing. And we're so excited to ask you all these questions and get started and help our community in any way that we can, because I know this is something that a lot of parents and children go through in the HIE community. So thank you. This is a big question, I'm sure, and it's multifaceted. But can you just explain cerebral palsy in terms of what it is, what it impacts, and the various types? Because I know there are a few.
Sure. So there are a few factors, a few points that define cerebral palsy, and then after that it gets very loose. But just to keep it simple, it's something that involves the brain, cerebral. It's something that involves movement. So somebody who has an issue relating to the brain, like some of our community members who may be on the autistic spectrum disorder, have significant brain involvement, but have fine movement patterns, would not have cerebral palsy. So it has to involve the brain, it has to involve movement, and it has to be something that occurs in the earliest part of life, so it affects development. It may be in the first days of life, it may be in the first few months of life that something happens, but we usually tend to think about cerebral palsy as something that happens right at the beginning of life or even before birth to the brain. Now, this is about HIE, so hypoxic ischemic encephalopathy is one of the main causes of cerebral palsy. It's often associated with prematurity. That's one of the main risk factors for cerebral palsy. It can be other reasons for lack of oxygen to the brain, aside from being born early and having a bleed in the brain. It could be due to a stroke early in life, and sometimes it's due to a genetic malformation of the brain. But all those things can lead to this syndrome where there's a problem with the brain that affects movement. Now, I think it's very important to remember that I'm saying the problem with the brain affects movement. It does not necessarily affect the person's ability to think. And I have colleagues that are physicians, I know lawyers, I know other people that are very high functioning, graduate degrees and so forth, who have cerebral palsy. However, many people with cerebral palsy do have some form of cognitive impairment. Now, cerebral palsy does have a very presentation. And Deanna, can I show a picture for a second?
Oh, of course. Yes, please.
Okay, I hope you're seeing a picture with 5 images of kids walking upstairs and things like that. And this is called the Gross Motor Function Classification Scale. And we tend to look at people with cerebral palsy along this scale. So people that are GMFCS1 are able to walk well in their environment, but they walk with some changes because of their cerebral palsy. Their muscles are tight. It will affect their balance and the way they walk, but they can do very well. GMFCS2 has more difficulty in the open environment and may have to use a handrail when they're going upstairs. When our patients start using walkers, wheelchairs, well, more walkers, canes, that kind of thing, and occasionally a wheelchair, they're at level 3. Level 4 uses a wheelchair for really almost all of their mobility, maybe can use what we call a gait trainer. And then level 5 is someone who's very dependent and needs someone else to help them with their movement. Aside from that, cerebral palsy is classified. Most children with cerebral palsy have spasticity, which is a tightness in the muscles, difficulty moving their muscles. That's called spasticity, but there's other forms too, which are called hyperkinesia, where the patient can move around, but the movements are poorly controlled. And then there's combinations of those things. The other way we think about cerebral palsy is what part of the body is affected. So we talk about hemiplegia, one side affected, diplegia, just the legs, the arms somewhat, but not as much, or quadriplegia, the whole body being affected. So those are the basic ways that we classify cerebral palsy.
I know you mentioned this briefly that HIE can be a cause of developing cerebral palsy. Do you happen to know the risk factor associated between a child with HIE and receiving a diagnosis of CP?
I don't have a percentage, but it's a very high risk. Many children with HIE will end up having cerebral palsy. Some children have their HIE palsy cause. I'm sure this other difficulties, learning, visual difficulties, thing without necessarily affecting movement. But it is one of the top risk factors for cerebral palsy, and so many of the children that I see do have HIE in their history.
And in terms of the signs or symptoms of cerebral palsy that our parents should look out for, what are those? Just so it's on their radar and maybe they can elevate that to their medical team.
Sure. So the earliest thing, I mean, the first thing is that in the earliest part of life is prematurity. Any child with prematurity is going to be at risk for HIE and is going to be at risk for cerebral palsy. Very often when a child's premature, they go to the neonatal intensive care unit, the NICU, and there they might get an ultrasound of their brain. Because children have open areas where the skull is not closed in different parts of their skull, they're able to use an ultrasound machine to look into the brain. And that can often tell us that there's been bleeding or damage to the brain. Sometimes an MRI scan is needed as well. There's an assessment that some physicians and many therapists are trained to do called the gross motor assessment. And they actually look at the patterns of the baby's movement. Babies should move in a very random kind of fashion. You should be able to look at a baby and not know if they're going to move their arm or their leg or which arm or leg next. When babies have certain patterns of movement, that is an indication that we need to be worried about their neurologic development. Now, I want to caution everybody here. You need to be trained to really know how to do this. Don't go home and look at babies and start saying, I'm worried about my baby's movement based on what I've just told you. The therapist will know exactly what this is. And this is only in the first few weeks of life. If you're talking about a child that's already 3 or 6 months old, these rules apply less. Once a child gets to be that old, what we start to look for is their development. And so, at 4 to 5 months, the child to start to roll one way, then the other way. At 4 to 6 months, a child should be able to be on their belly and lift up their head. 6 to 9 months, a child should be able to sit. So we start to look at these things. And if a child is not meeting those developmental criteria, we start to worry that there's a problem. And one of the things we worry about is cerebral palsy. Another thing is the spasticity that I mentioned. Now, very often children born with a problem with the brain that causes spasticity are actually kind of floppy. They're actually loose, and they don't get tight until like after a year of life or that kind of thing. But at that point, they start to have, their legs are tight. I can't separate their legs well to change their diaper. That's something that parents know. The other thing is just poor development of movement patterns. So for example, when you have a child who's 1 year old who seems to be very right-handed, that's really not what we'd expect to see. Now, I say that with a lot of caution. My oldest child at 4 months was absolutely right-handed, and she's right now. But when a child is showing a lot of handedness early in age, we start to worry, is there something wrong with the other hand? And that should be checked out by a physician. A physician should know those things. So problems with development, unusual patterns of movement, unusual patterns like really always using one hand. They get around really well, but they crawl on their belly like an army crawl. They roll more than they crawl. Some patterns of movement like that are things that make us worry about cerebral palsy. Also, people with cerebral palsy often have difficulty with their eye tracking. So
Mm.
there can be some issues with the eyes not up correctly. That might be something. I've seen 15-month-olds with glasses on because they've been detected to have these eye problems. So that's something to look for as well.
Yeah, so I'm hearing a lot about, gross motor development tests and just milestones where if, you're not passing them, then it's cause for concern and to start looking into it more. My next question is, when all of these things are determined, who officially gives a CP diagnostic? Is it a pediatrician? Is it a PM&R? Who does that?
Yeah, so let's talk about that pattern of that pathway of care a little bit.
Yeah.
So everybody here is really good about taking their new babies to their pediatricians, and you take them at a certain cycle of certain timing to get their shots and to get checked out. And every pediatrician has a list of developmental milestones and questions in their head, and they check out the baby. And one of the if the baby is not starting to roll over at that 6-month checkup and doesn't look like they're starting to sit and their head's still kind of floppy, that's one of the common times when the pediatrician will talk to the family about developmental concerns and then start making referrals. So there are a few different pathways that pediatricians could choose to make those referrals. I think one of the most common is going first to a pediatric neurologist, a neurology doctor. They're very commonly the doctors to make the diagnosis. Now, how do they make the diagnosis? Well, I've told you a lot about developmental milestones. So the neurologist will, has expertise in understanding milestones, and they'll look and they'll measure those things for the child. They'll look at the child's muscle tone. So muscle tone I tend to think about that as like having a thermostat in your house for heat. So you have a kind of thermostat for your muscles. So there are some kids that are kind of floppy and they can't hold their heads up and their trunk seems really loose. That's a low muscle tone. A lot of kids with cerebral palsy will have that, but other kids with cerebral palsy, and I mentioned also some of those kids later on in life, will start to get tightness in the muscles where you can't move the muscles. You have difficulty moving them through what we call the range of motion. Your range of motion, for example, this is my wrist range of motion. It's the range that I can move it through. So you have difficulty moving your arms and legs through the range of motion. Something the neurologist will have some expertise in. And then the neurologist will do tests. So one of the most common tests they'll do is the MRI scan, the magnetic resonance imaging, which is let's call it an advanced X-ray kind of study. It doesn't use any radiation, so it's very safe. It uses a magnetic spectrum for taking its images. Generally speaking, when young children get an MRI, they're going to have to be put to sleep. They're going to have an anesthesia appointment, and they're going to have anesthesia, so they're completely asleep. Otherwise, they'll move around too much. And for those of you who have not been through the MRI experience, it's a little disconcerting. You kind of go into a tube. There's a lot of noise and this kind of thing. Kids just can't take it. Adults have trouble with it as well. But we usually can do it without the sedation, but kids need to really go to sleep for it. There's some other tests that your neurologist will probably recommend. They will look for syndromes that aren't the classic syndromes that cause cerebral palsy, like genetic syndromes or what we call metabolic syndromes, which means some of the chemistry in the body may be not functioning correctly, which is usually due to genes. And they'll draw some blood to look for those kind of things. But the biggest test they'll do is the physical exam for the things that I've mentioned. They'll check the reflexes. Children with spasticity will have very active reflexes, they'll jumpy reflexes. Now, again, I caution everybody, kids tend to have jumpier reflexes than adults anyway. So don't go home and test this on your kids.
Right.
You have to have the neurologist or the physiatrist do it to make sure that's correct. Now, aside from the neurologist, there is the physiatrist or physiatrist, which I am, and I do a lot of diagnosis of cerebral palsy. I do some of the same things that the neurologist does, some of the same testing and that kind of thing. The difference between what I do and what a neurologist does, well, in many cases we overlap. I have a lot of colleagues and friends who are neurologists, and our work with cerebral palsy can be pretty similar. But generally speaking, most neurologists focus on the diagnosis of cerebral palsy. They may focus on children with cerebral palsy who may have seizures, which is a common complication of cerebral palsy, and they may treat that. We can talk about that more in a little bit. Whereas I am the doctor who tends to follow the child over the long term and think about their therapy needs, their functional needs, and that kind of thing. So when we get to that point talking about it, generally speaking, after the diagnosis is settled, that's where the physiatrist will come in more. Another very important doctor in this whole setup is the orthopedic surgeon. So children with cerebral palsy will often have problems with their joints, with their like their hips, for example, is a common problem. With the muscles getting tight, their joints will not grow correctly, their limbs will not grow straight. And so the orthopedic surgeons get involved, especially if surgical care is needed. Orthopedic surgeons are also often called on to make the diagnosis of cerebral palsy. It's another choice that your primary care doctor might have, depending on the pattern of practice in your area. They may send them to the orthopedic surgeon for diagnosis. So we work together, myself, the orthopedic surgeon, the neurologist, neurosurgeons get involved, and sometimes developmental pediatricians. We all work together on these kind of things to diagnose cerebral palsy. Each of us has a little bit different aspect of what we do aside from diagnosing cerebral palsy, but we're all capable of diagnosing cerebral palsy.
So it's definitely a group effort then. I mean, all of these medical professionals are coming together to help with that.
Uh-huh.
So my next question is, we have a couple of questions that have come in that are relevant that I will ask. The first of which is, when would you say most cerebral palsy cases are diagnosed in a child's life? And is there an age range? And depending on your answer, I might have a follow-up for you too.
Sure. So I would guess that it's very common to diagnose cerebral palsy about a year of age. And because by a year of age, it's pretty clear that the child is having difficulty with their motor development. Now, I used to see a lot of kids that were 1 year old that were not walking yet. And that was a lot of fun because they were normal kids. And so I got to play with a normal baby for half an hour. But the walking range we talk about, we usually use the numbers from 18 to 21 as being late. After like 21 months, but I'd say anything after 15 months is a concern, and after 18 months, it's late. And so that's when people start to get nervous about cerebral palsy. Now, some kids, have a more involved cerebral palsy, like we talked about with the graph, the GMFCS5, and they'll have very poor development even from the beginning of birth. And so they'll get a much earlier diagnosis. But most commonly, it starts to be about a year. Now, there is some thought out there that cerebral palsy should not be diagnosed until children are 2 years of age, because some children get diagnosed with cerebral palsy and then it kind of goes away. That's because they were not diagnosed correctly, which is, they looked like cerebral palsy, but they didn't really have it. We see that a lot less than we used to because of the availability of brain imaging and some of the other testing that we do. But there are some places that still say until they're 2 years old, you can't have a fixed diagnosis of cerebral palsy. We're kind of moving away from that. I think the answer would be a year to 18 months being most common. For very, very mild cases, I have diagnosed cerebral palsy when children are 8 to 10 years old. And there have been cases that I know of where people get diagnosed as adults. I don't know. I always kind of walked funny. I was always clumsy,
Yeah.
But, my family didn't have a lot of money. We didn't get to see a lot of doctors. And then we do the scans and they have cerebral palsy.
And that's kind of my follow-up question, because we do have some parents in our community whose children are 8, 9, 10 years old, and that's the first they've ever heard of their child getting diagnosed with cerebral palsy. So the follow-up question is, are there pros or cons to being diagnosed within that typical age range you say of like 18 to 21 months or
Yeah, yeah. Well, our thinking now is the earlier the diagnosis, the better, because we can start interventions. That's definitely
right?
true. I will say though that if someone's 8 years old and we're not sure about their diagnosis of cerebral palsy, they haven't been diagnosed, they must be pretty mild. If
Hmm.
they're if they're very, very mild, then they need less and that kind of thing. However, even that child, for whatever concerns they may have, it might have been easier to deal with it earlier. So, for example, you a lot of types of those things. Nobody ever thought much about it. A lot of kids walk on their toes, but this child walked on their toes because cerebral palsy and their ankles tightened up. And so with that, they so then they may need orthopedic surgery to release those contractures where we could have done it before with physical therapy. So early diagnosis and early intervention is always a plus. Now, some people don't like to get the diagnosis early because they don't want to label their child.
Hmm.
I I understand that. The problem is that if the child needs the services, you can't get it so well without the diagnosis. The insurance companies need the diagnosis in order to give the services, and we want the child to get all the services they need. I think it's really, really important to remember, this is something I think families struggle with, that there are, many, many high level executives, doctors, lawyers with cerebral palsy. Cerebral palsy should not be a negative thing. It just simply describes how you move, a little bit about your neurology. It doesn't tell who you are. So there shouldn't be anything wrong with getting a diagnosis of cerebral palsy as early as possible to start getting needed services.
Awesome. We do have another question too, that just came in. When would you recommend? The question is, when should we get a GMFCS rating? Right now, their child is 7 months old with spastic quad CP. What would you recommend for that?
Yeah, so the answer to that really is kind of an answer to a different question, and that is that um, it goes back to what I actually just talked about, is that if your child, if you suspect that your child has movement problems, cerebral palsy, that kind of thing, I think they should be seeing a physical medicine rehabilitation doctor, a physiatrist, as soon as possible. Not Don't run out. Don't You can watch the rest of this webinar, uh, but you talk to your doctor about getting a referral. When they get that referral, one of the first things that doctor will do is assess if the child has cerebral palsy, is give them a GMFCS score. So it's more about getting in to get the interventions and treatments that your child needs, and then the GMFC score comes with that.
Wonderful. Thank you.
Being a doctor, neurologist, orthopedist, that kind of thing.
Yeah. And I think that's a good segue because now we're going to kind of get into the role of a PM&R physician. Um, so when does a PM&R physician come into play during the diagnostic journey? I know you kind of talked about that a little. And what is the role of that doctor?
Yeah. So there's a few different ways I would describe the PM&R doctor. I think the PM&R doctor, we tend to think of ourselves a little bit as like the coordinator, the quarterback, that kind of thing. That may be saying a lot. The honest truth is that you, the parent, are the quarterback. You are the coordinator, but we like to be an important member of your team. So the PM&R doctor is interested in aspects of disability, and it touches every aspect of disability. So, and I see children, months old, weeks old sometimes, as I say, I just talked to a patient who was 77 years old. So to do the full range, and we look at the full life experience of anybody with disability, including children with cerebral palsy. So we can go through a list of things that we do. We work closely with therapists. So I work closely with physical therapists, occupational therapists, speech and language pathologists on all the aspects of function that they do in life. So we look at all aspects of mobility. How do you get around? How do you walk? Well, does the child have difficulty walking because their muscles are tight. So one of the main things a rehab doctor does is work with spastic tone. We do that through giving medicines. We do that through, first off, prescribing therapy. That's first. We do that through giving medicines. We do that through prescribing braces to help the feet get into proper position, or take a hand out of contracture to put it in the right position to use a computer. We do that by doing injections of botulinum toxin, Botox, or it's one of its cousins, Xeomin or Dysport or something like that, to loosen muscles. We do that by making recommendations for certain surgical procedures, like the selective dorsal rhizotomy, the intrathecal background pump, and depending on how much time we have and so forth, I can talk more about all of these things. But we also talk about many other things in life. So I ask how the child is eating. And if the child's not eating well, we work with our occupational therapist or speech and language pathologist on feeding issues. Sometimes we talk about children that need to have tubes put in for feeding. We talk about the bowels and bladder a lot. You know, people are concerned about walking, but there's just nothing like having your bowels working. So
Right.
the truth is that bowel problems are one of the main reasons that adults with cerebral palsy end up in the hospital. So we talk about bowel regimens and bowel programs and how we can get that working better, and any issues with the bladder, which are less common in cerebral palsy but do happen. We talk about how is your child doing cognitively? If the child is able to participate in school performance, in school, how is the school performance? And we work with our psychology colleagues on these kind of issues. Our psychology colleagues also help us with adjustment to disability and some emotional issues. Unfortunately, people with cerebral palsy and children with cerebral palsy have higher amounts of mental illness issues, including anxiety, depression, and other psychiatric illnesses. So we work with our psychology and psychiatry colleagues on these things, including using medicines. I do a lot of work with behavior as well, again, with my psychology colleagues, and some things with medications. I was talking about helping children with walking, and then if walking is not the best option, then we talk about wheelchairs. And physical medicine rehabilitation doctors know a lot about wheelchairs and how wheelchairs are designed and what's the best wheelchairs and wheelchair technology. I just had a big meeting yesterday where we talked about adaptive sports. So I'm going to want to talk to you about your child's physical activity and how we get them involved in sports and what kind of programs we can find, and answer your questions about exercise and sports, and just other things about getting a child to participate. Usually for children, it's not as much of an issue because the schools, they spend the day in school, they're participating and that kind of thing. But what can we do aside from school, like in sports and other kinds of activities? And then once school is no longer on the daily schedule, what can we do to try and keep the person more active and participatory? So Physiatrist really deals with all of those kind of things.
And it's kind of like a lifelong range of services I'm hearing, from the moment of diagnosis to, like you said, like after school age.
Right.
Does every child or does every patient with cerebral palsy, are they absolutely guaranteed to have a PM&R physician, or is that not necessarily the case for everybody?
It's not the case for everybody because there's not enough of us, especially when you move away from the big centers. Patients that travel for hours. Telemedicine has been a blessing. We are looking for ways that we can use telemedicine to do better outreach in this community. There's a lot of things that we do that we can do through telemedicine. I can talk to you about many, many things. I can talk to you about exercises that you can do to help your child's tight muscles. I can assess some of that somewhat in telemedicine, and we can talk about taking medications. If we're going to do Botox injections, you have to come and see me. I haven't figured out how to do that in telemedicine yet.
Yeah. Right.
We can talk about some of the mental health issues. We can talk about some of the bowel issues. We can talk about many, many things through telemedicine. So telemedicine has been very helpful for giving outreach to the community. Physiatry is not big enough yet, though, so that it's known everywhere, and not every child has a physiatrist. I'm biased. I think every child benefits from having a physiatrist. I think there's things that we talk about and that we do that go beyond what other specialties do. Now, I will say again, I have colleagues that are developmental pediatricians, neurologists, and they have adapted their practice, and their practice is very different from some of those folks that I work with. they do a lot of what I do, but they have their own special focus on things, and I think ours is a little different, and I think it's very, very useful.
Wonderful. I think now is a great time to kind of go into next steps and treatments because you started to talk about those too. So once a child has received an official cerebral palsy diagnosis, what typical next steps can the family expect to follow? Like how is their development typically monitored? How often? By whom?
Well, so I'll see young children like every 3 months for a while, and every 6 months, and I think that's, in my practice, we do most of that monitoring for the development and that sort of thing, and then we refer out to our colleagues when we feel there's something needed. So I will refer out to the orthopedic surgeon. We actually, some of our referral goes into a multidisciplinary clinic. So I might see a patient and I say, I think we need to look at your spastic tone. And then there's a clinic where we'll have a rehab doctor, an orthopedic surgeon, a neurosurgeon that will assess the child, and a physical therapist. And so that will be helpful for that. Sometimes I just do that myself, but sometimes I ask this clinic to do that kind of work. Um, but I'll be, like you say, monitoring, like every 6 months and that kind of thing for that development. The journey starts, especially, I don't know if our webinar here is going beyond American audiences, but certainly in America, there is laws about individual education planning and school systems. So in every state in the union, there's a federal mandate that says that you get services through the school. So it starts with a call to your school special education services, and you get evaluated, and then there's a meeting called an individual education plan, an IEP, and then the school provides physical, occupational, and speech services related to the child's educational needs, which at the youngest ages is pretty general. So that's where that starts. Often the children that I see get additional services through one of our therapy centers, through a practice at the University of Michigan or one of the private practices around us, to get additional PT, OT, and speech services. That's kind of where it starts. One of the other earliest things that we do is, we look at mobility. So if a child is having difficulty walking by themselves, does the child need a walker? Does the child need crutches or canes or something like that? So that's an intervention we think about early, as well as braces for the feet, plastic hard shell braces that help form the feet into a better walking position. Children with cerebral palsy, their feet often point down or out or in, and by putting these braces on, they can walk much better. And it gets to be a certain point where we start to say that spasticity is really interfering with their ability to do things, and they're getting physical therapy, they're getting range of motion, you're stretching them out, but they're still pretty spastic. So we start to think about what else can help them. There are medications that can be helpful for spasticity. One of the common ones is baclofen. Another one is Xanaflex. Medications, I try to avoid them for my children I see that are school age, and especially those that are really benefiting from the classroom, because they tend to sedate a bit. I think they can cut down on school performance. I don't have great evidence of that, but they are sedating. And my adults who have cerebral palsy tell me they can't take these medications and look at a database and do their work, and it's difficult to drive. And so I'm just imagining how that goes into the school performance. So I stay away from those if I can. And then I think more about what joints exactly are tight. Is the elbow joint tight so they can't stretch out their arm? Well, then we can put botulinum toxin into the muscles here to stretch that arm out. Commonly, we put botulinum toxin into the hamstring muscles behind the thigh, or the muscles behind the calf, the gastrocsoleus muscles, so that loosen those muscles up so the child can walk better. Many children have the problem where their legs cross over each other, and it makes it tight for them to walk, and we put Botox into those muscles as well to loosen them up. So Botox is a very common treatment. Often Botox is a bridge to a surgical treatment. And then we start thinking about surgical treatments for kids with spasticity. So there's a variety of surgical treatments. The most common is orthopedic surgery, where the orthopedic surgery, I refer this to an orthopedic surgeon who will do a procedure where they actually cut into the muscles and sew them back together longer. So the muscle is longer and is less tight. Sometimes they'll do work on the bones if the bones are out of place, or if they turn the bones. Sometimes the hip joints come out of place and they put the hip joints back in. So the orthopedic surgeon has some of those options for us to help with those kind of things. The tight hand, they'll loosen that up so that the hand will be in a more functional position. All those are things that the orthopedic surgeon can help us with if the Botox and bracing and stretching isn't enough. We go to our neurosurgery colleagues for a couple of interventions. One is the selective dorsal rhizotomy. That's a big procedure, and I encourage the audience to look that up more than I can really explain the whole thing. But basically, that's a procedure where there's a major cutting into the back, and then we actually open up the bone and we look at the nerves. We test the nerves using electrical stimulation, and then we cut some of the nerves. And by doing that, we decrease the spasticity and the legs work better. The child has better control over the legs and they're less spastic. This has been a very, very successful surgery. I've been involved with it for about 35 years now.
Mm.
And it's been shown study after study to be effective and useful, and with a very low rate of bad effects and negative effects. And there's studies that follow kids into adulthood. We've done a couple that have shown continued benefits from this surgery, at best that we can tell. So we recommend that quite a bit. It's most commonly done on children between the ages of 3 and 8 who are walking, able to walk even with a walker. That's most common, but we are expanding the surgery now to children who are not able to walk, to even children where we just want to be able to help move their legs better so they can get better care. Another treatment the neurosurgeon helps us with is the intrathecal backlift and pump. That's where a metal pump about the size of a hockey puck is placed under the skin in the belly, and a catheter goes around and drips a medicine onto the spinal cord. By doing that, that has some of the same effects of the rhizotomy of decreasing the spasticity. And by doing it that way, that medicine does not cause that brain fog effect. And we've actually studied this. It does not cause that brain fog effect that I talked about if you take the medicine as a pill and it goes everywhere in the body. Here, it's very focal and it's a very small dose. So, for example, I might give your child 30 milligrams of baclofen to help their spasticity. If I give them a pump, I might give them less than 1 milligram.
Wow.
So low dose, focally placed. The pump is an obligation. It needs to be filled every few months. Every few years, it needs to be taken out and a new one put in because the battery dies. They don't just change the battery; they put a new pump in because after you change it every 7 to 10 years, and they've improved the technology by then, so you get a nice new spiffed up pump. The pump has a series of things that can go wrong with it, like every other device that you have, your computer and your phone and everything else. But they have an excellent success rate, and I would tell you that the things that go wrong with the pump, it's tolerable. Just like you wouldn't refuse to have a car because it has problems, you wouldn't refuse to have a pump because it has problems. It's very, very tolerable. There's one more thing the neurosurgeon does, which is less common, which is called deep brain stimulation, where they put a device in that stimulates parts of the brain. This is just new with cerebral palsy. It doesn't apply to most kids, so I won't spend a lot of time talking about it, but just for your awareness.
Yeah. We have a question that came in that's relevant to medications, and the question is, when using medicine, does the effectiveness of that medicine diminish long term? Like if you've been on a medication for like 10 years, is there a benefit to switch to a different one that does the same thing, or not really?
Probably, but we're not 100% sure about that. I think that's true. I see adults who've been on baclofen for 25 years. I take them off the medication and they say, doc, I don't feel any different. I start them on new medication. They say, oh, now I'm feeling looser again. It's hard. I can tell you my body is tighter than it was 25 years ago. So it's hard to get a sense when you start a medication when you're like 8 years old. Now you're 33. Your body's tightened up, but you've just gotten older. You're so changed. Right. That it's hard to know, and I do think it's because the medication becomes less effective. And what I don't want to do is just keep increasing the dose. There's a certain point where increasing the dose doesn't help anymore, and it just causes a tremendous brain fog.
Yeah. I'm going to wait for just a couple more questions to come in and sort them. In the meantime, I would love if you could share with our community any suggested tools or resources that you believe would help them learn more about or better understand cerebral palsy?
Yeah, I'm happy to do that, and I'm going to share my screen again if my computer will work. Yeah, and I hope that you can all see the mycp.org website. This website is associated with the Cerebral Palsy Research Network, which is something that I am one of the steering committee members of. And this has a lot of information, including on adults with cerebral palsy and just a lot of information about cerebral palsy. And there's one thing in particular, there's the Cerebral Palsy Toolkit, which is on this website of mycp.org. And it has a lot of really good information people would benefit from hearing about. So you can download this and look at it on your computer. I think there's some printed versions as well too, but downloading it seems to work well. And then the other website that I think people should look at is the Cerebral Palsy. The Cerebral Palsy. I'm sorry, I'm in trouble. Cerebral Palsy Foundation. Oh, I'm sorry, that was not the right one. I'm going to come off that before I
That's
share anything.
okay.
I shouldn't. Um, yeah, whatever it is. So it's Cerebral Palsy Foundation, CPF, Cerebral Palsy Foundation. People can Google that and probably find it quicker than I just did. The Cerebral Palsy Foundation website has a lot of videos, short podcasts about various aspects of life with cerebral palsy, and I found that to be something very, very helpful. I would warn people about just Googling cerebral palsy and going to websites. A lot of those times, the attorneys, the lawyers have bought, the rights to have the highest Google. And so you'll get onto a legal website, and then you'll be solicited to be contacted by a lawyer who will try and get you to sue because your child has cerebral palsy. And I'm not telling you what you should do, but I don't feel those websites are as authoritative as the websites that I just pointed out. You can go to the NIH website, National Institutes of Health, too. That'll have some information. I think the websites that I just showed you probably are the best ones.
Wonderful. And we'll be sure when we do our key takeaways on our blog, I'll link all those sites for all of our community members too. So that way they know they're going to the ones that you've recommended.
Yep.
We have, I think, just one more general question, because, of course, we have some specific questions coming in that might be too hard for you to answer because you don't know their child, et cetera, et cetera. But we do have a couple parents wondering, going back to the GMFCS rating, does it matter if a child doesn't have a rating? And when is it too late to get one if it's needed?
It's never too late. It's just a description. It's nothing all that important.
Okay.
If you don't know your child's GMFCS, it's nothing all that important. Next time you go to see your doctor, your rehab doctor, your physiatrist, your neurologist, your orthopedic surgeon, ask them what your child's GMFCS is. They should be able to tell you in an instant. It's not hard to do. I can rate your GMFCS just by looking at you, and it's good to know, because if you know your child's GMFCS, then if you are talking to another doctor, you could start with that. If you were to ask me a question, for example, if you said my child's GMFCS 2, I would immediately have a picture of how your child moves around. Not of your child. Not everybody is the same. Not everybody's stereotyped. It doesn't typecast who you are, but it gives me a little bit of a picture. I will mention that there are a few other scales. There's one called the MAX, the Manual Abilities Classification Scale, which rates your ability to use your hands for things. There's the Communication Function Classification Scale, the CFCS, which rates your ability to communicate in a community way. There's even one called the EDAX, which is the Eating and Drinking Abilities Classification Scale, which rates your ability to eat and drink, which is useful if you're looking at therapy along those lines. We tend to use these scales. At my clinic, we rate everybody's gross motor, manual abilities, and communication, and it doesn't box your kid in or stereotype them, but it gives you a bit of a picture of what the child looks like, so that you can be thinking about, what kind of interventions and things you'll be talking about with the family.
Wonderful. Thank you so much. And some of the questions that came in, they were asking about timing and onset. If you're one of those people wondering, I just recommend that you go back through this video and take a look. I will also post the full recording of our video on our YouTube channel a little bit later today once I process it, make it look pretty, etc. And we'll post key takeaways and everything for you too. So thank you so much, Dr. Hurvitz, for joining us. That was so informative and so helpful, and we're just so grateful for you to be part of our community and offer us your knowledge and insight. So thank you.
Yes, my pleasure. And thanks everybody for your attention today. Have a great weekend.
Wonderful. Thank you.
Bye bye.